Welcome back, everyone. It's a great pleasure of mine to introduce a colleague and friend who I've known for many years, Dr. Alexandre, or Professor Alexandre Persu. He has enormous experience with fibromuscular dysplasia. In fact, I don't think I can pick up a journal any given month where he hasn't written a paper about FMD or something related to it. He published the 1,000 patient experience in the European Registry. He's done some important genetic work related to FMD. And it's a great pleasure to have Professor Persu here virtually from Brussels, Belgium. Alexandre, welcome, and we look forward to your presentation.
Thank you very much, Dr. Olin, Jeffrey. Do you hear me well?
Yes.
I will try to show my slides. I don't know. Do you see the slides?
I do, yes.
I'm really grateful to FMDSA and the organizing committee to invite me to this meeting. It means that we are a true community, patient and physician across the Atlantic, despite COVID and other hurdles. And today, I will try to update you briefly on behalf of many others on the European FMD Initiative and Registry and share with you a few findings. Do the slides move?
Yeah, you're okay now, I think.
You see the second slide, I mean.
Yes.
Thank you. So this was the start of the Belgium FMD Initiative in the wake of the French initiative, and also the first start of the European initiative. This was in Brussels. We are not numerous, though there were key people, which you can see here, such as Pierre-François Plouin, for example, my Belgian colleague, Professor van der Niepen, and a group of motivated Americans, including Pam Mace, despite the terroristic threat by that time. So this was a great moment to start. Despite the circumstance, we feel supported. So these were the scope of the European FMD Initiative. We showed at one of the first meetings to help to standardize clinical practice in Europe, to update the consensus, the European consensus, to establish a network of expert centers, establish a European patient association, establish a European FMD registry, contribute to genetic dissection of FMD and research in Europe. And so, as you know, thanks to the fantastic collaboration of Dr. Gorning, Dr. Olin, Dr. Plouin, we did this update, and not only we did this update, but all along we harmonized with a US consensus and made a single international FMD consensus. For the rest, I think we have progressed, and I will try to show you how in the next slides. So the European FMD Initiative has been launched at the end of 2015. Now is a mature initiative. The registry includes about 2,000 patients from 20 countries. And since the last presentation I made at FMDSA, the number of countries have remained approximately the same, but in many countries, the density of center has increased, especially Italy, Spain, Germany. We have now, besides Poland, in Central Europe, Slovakia, soon Austria. And so I would say that Northwestern and Central Europe are quite well represented. We still need more from Scandinavia. We have Finland, but not the Scandinavian country, or very little, and more to the east of Europe. But I think we are progressing. We have a quite representative network, and we are also in collaboration with several countries abroad, beyond Europe, mainly Japan, China with the Shanghai Center, and Argentina. At the Warsaw meeting, I showed this slide with this famous Van Gogh picture and said it was time for harvest. We could at last show some results, and by that time we have included 1,000 patients in the registry. The first publication on behalf of the European FMD Registry, now named FERI, with an international branch, was this one in cardiovascular research. I will not show figures or statistics in this presentation. Rather, I will try to show you, let's say, the relevance of what we have done. And I think what is important is that it includes many authors from many countries. So it went well beyond the established known center involved in FMD research. And in this setting, we try to confirm, to replicate many things done already in the French Arcadia registry and by the US FMD registry, such as to compare patients with focal, multifocal disease, young versus older patients, those with and without dissection, with and without aneurysm. And I think it was the first time in Europe, at least, that it was done at this scale and going beyond the few known centers by that time. And this is summarized in this picture. I have no time to go in detail to show you the new thing, the difference and similarity with what was known before. But I think even this is important to show that what was shown in the US is also true for Europe. And one of these findings is about the dissection, as mentioned by Dr. Olin. Dissection is strongly associated with male sex. And this is something we find as well. And if you wish to know more, I invite you to read the discussion where we compare indeed with the US registry for FMD. A second work was this one. We retrieved data from the pregnancy of 237 women, over 500 pregnancy, subsequently diagnosed with FMD and included in the registry. And what we show here, compared to historical group of women with normal and hypertensive pregnancy, is that patients with FMD are at an increased risk of premature delivery, of hypertension during pregnancy, and to a lesser extent of preeclampsia, that is a severe complication of pregnancy with hypertension and proteinuria. But the good news is that we found very few dissection or aneurysm rupture. Now, this has to be taken with grain of salt because our cohort includes less patients with cerebrovascular FMD than in the US. And so probably the risk mostly reflects the presence of undiagnosed renal FMD. But still, there is an important message, is that I think hypertensive women planning to be pregnant without explanation, they should be screened for FMD, probably not only with renal duplex, but maybe CTA or MRA to diagnose and, if needed, to revascularize FMD-related renal artery stenosis. So let me be clear. Don't be afraid by these slides. The risk we found in patients with FMD is much less than in inherited arteriopathy such as vascular Ehlers-Danlos loss, and probably if the diagnosis is made in time, this risk can be decreased, as it can be decreased also in hypertensive women at large. A third publication, which is also from FERI in the large sense, but in reality based on a data set from Leicester in the United Kingdom, is this paper issued a few days ago in JAMA Cardiology, and with a collaboration with Professor David Adlam, which is a head of the European Spontaneous Coronary Artery Dissection Registry. As you know, it has been shown by Jackie Sow and many others afterwards that a patient with such a kind of cardiovascular event were also mostly women, middle-aged or young women, they have often multifocal FMD lesions in extracoronary vessel that in other part of the body as the heart. And there were variable reports. At the beginning, it was said 80% have FMD and other abnormalities. Then it decreased a little bit. And in this publication, we tried to see in over 170 patients in an unbiased way, blinded, what is the proportion of FMD and also the complication described by Dr. Olin earlier, that is aneurysm, dissection, and also tortuosity. Why do I say blinded and unbiased? Because the people who examined the image, they had in front of them a mix of image from patients with SCAD and from healthy volunteers, similar age and women proportion. And so they didn't know if the patient had a SCAD, they didn't know the clinical history. So they would interpret, for example, a milder string of bead in the same way, whatever the diagnosis of SCAD, FMD, or healthy volunteer. And so what we find here is that finally, the proportion of patients with SCAD who have also a string of beads, at least in one extracoronary arterial bed, is in the range of a little less than 30%. The proportion of patients with multivessel is much less than what is found in patients with primary FMD in this cohort. And also what I would call complicated FMD is quite rare, with less than 10% of aneurysm and less than 2% of dissection. What is maybe more important is that virtually none of these patients had clinically significant event, stroke or whatever, during their follow-up, besides the SCAD itself and possible recurrence. Another, I think, relevant finding is about tortuosity. We have assessed tortuosity very carefully, both looking for the classical S-curve, but also measuring in a more, let's say, mathematical way, the number of loops, the ratio between the trajectory of the artery and the right line, and we found no difference between patient with SCAD and control in terms of prevalence of tortuosity. And this irrespective of age, irrespective of the presence of FMD or not. So for sure this has to be replicated, but our impression is that tortuosity is not part or may not be part of the phenotype of SCAD, because we find a lot of tortuosity, but this is also true in the controls. And the single association we found with tortuosity was with the presence or absence of hypertension. So overall, the message of this paper from the clinical point of view and for the patient and their family is that we think that the presentation of FMD, extracoronary FMD in patients with SCAD is usually milder, that there are less complicated forms, and that the prognosis is generally good. This does not mean that it has not to be detected and followed up, but at least this is a rather optimistic message. From a scientific point of view, I think it's, well, the debate is still open, but we are not convinced, not sure that FMD associated with SCAD is absolutely the same disease as primary FMD. An intriguing finding is that, as you know, patients with SCAD, they are overwhelmingly women, whether the other kind of dissection associated with FMD are found more frequently, maybe not in the majority, but at least are associated with male sex. This is a publication to which we took part with others. It's again a collaboration from Ferry with Dave Adlam, but also with Bart Lois. So Pam Mess would see that Bart Lois finally came back with some answer. And this is one of many genetic publications showing that there is an enrichment of rare variants in Lois-Dietz syndrome gene, this tortuosity syndrome described by Bart Lois, in patients with SCAD, but not in those with FMD. And so this is consistent with the fact that maybe SCAD-FMD and FMD are not just a variant of the same disease. So again, I agree there is room for debate on this. And also in a very excellent recent review by Esther Kim and Santi Ganesh, it is shown that the genetic background is partly shared, but not entirely. Now, if you have looked, or if you will look, and I strongly recommend it, to the on-demand talk by Nabila Bouatia-Nagy from Paris, you will see this impressive endeavor, a genetic-wide association study coupled with a transcriptomic-wide association study, which in addition to the FACTIA1 gene already identified by the same group, identify new genes potentially associated with FMD, genes involved in arterial structure and function. This is not by FAIRY, but we were one of the main contributors. And I would like to emphasize that this work is basically a work not only of Nabila Bouatia, but with Santi Ganesh and the top US investigators. So it's a truly transatlantic collaboration, and we are proud to have been part of it. Now, the last work I would like to show you is about urinary proteomics. We aimed, in collaboration with Professor Mishak, an expert of this approach, to search for an array, a set of peptide degraded from proteins, which can be found in a urine sample of the patient using classical method, I will not go in detail, that are shown here, and FMD. And so this is the typical plot which show intensity of peak versus migration velocity. And you can see, even if you are not familiar with this, but the image you see, these peaks, like a landscape in blue, are not similar in patients with FMD and control. What we have found basically is that there are a set of genes that are differently expressed in patients with FMD versus control. Mostly are in fact overexpressed. And this is a key slide. It's for sure it's a pilot study because the FMD cohort were rather small, but still we were able to replicate in two independent groups, one for Brussels and one from Pisa with Dr. Rosa Maria Bruno, who is now in Paris. And what you see is that using a scoring, including the differentially expressed peptide in the urine, you can discriminate quite impressively well, in fact, between patients with FMD and controls. And the patients, the controls that behave like FMD patient, after all, they might have FMD because it's not such a rare disease, but overall, the discrimination is good. And what I have to say in favor of this work also is that we did not only include healthy control from general population, but also patients with chronic kidney disease and myocardial infarction with likely other vascular atherosclerotic abnormalities. So we find that our findings are quite specific for FMD. And in fact, this array of peptides mostly include collagen-derived peptides, which is consistent with the histology, but also with an ongoing process, metabolic process. So it would mean that the collagen that is seen in the older histological description is not just a scar, that there is a constantly ongoing process. I have also to say that this score, this proteomic score, was correlated with some arterial parameter in small, middle-sized artery, and this was done by Rosa Maria Bruno in Paris within the FMD group. So I think this supports our result, but for sure is a pilot study. It nicely complements the important work done by another methodology by Dr. Olin and Dr. Kovacic, and we have to go on, we have to confirm, we have to see other and larger groups. Now, in the aims of FAIRY, there was also to have an FMD patient association, and this patient association has been possible only with a few motivated patients, and the lead and very important person is Dr. Kathleen Jamison. from Belgium and UK. And now we have a website with validated information on the disease. And this exists in several languages: French, Dutch, English, Italian, Polish, Croatian, and the last one is in German. So if you have patients who are not familiar with English, or if you are patients speaking this language, do not hesitate to see it, and we aim to add new language, I hope, in the next month. Thanks to FMDSA, we were also able to propose a clinical basic presentation on FMD in most of these languages, and I would like to thank the different specialists who gave this talk, translated them in a very short time, and who are really, most of them, the new generation, also with more ladies involved in FMD research and very dedicated physicians. You can see their name. I invite you to listen to their talk if you speak the different languages. Finally, and this is my last slide, I'm speaking on behalf of all the FERI group, the European investigators, and many of them were present at this meeting at the Royal Belgium Academy of Medicine in 2018, already mentioned by Mrs. Pam Mace. And beyond this, I would like to thank all the American colleagues who were so inspiring for us. Dr. Olin, Dr. Gornik, who was so kind to co-chair the meeting with me. To thank also Mrs. Pam Mace and FMDSA was also there. And last but not least, as already mentioned, Mrs. Kathleen Jamison, who was at the origin, after the Dutch, done by other person, of the Belgium FMD Patient Association, and now of the Euro FMD network. And I know she's also very active as a volunteer for FMDSA. Thank you very much for your kind invitation. I'm happy to answer to any question.
Okay, thanks. We only have a minute or two for questions, but we're going to have a long question and answer period later, and you're more than...
I will be there at the long Q&A. I will be present.
Okay, so where are the questions? The urine study, I just want to ask one question. The urine study that you published, the data look very impressive. I mean, almost too good. I mean, if this is the case, are you suggesting that this will be a way to diagnose, do you have FMD or don't you? And for family members of patients with FMD, can you use something like that rather than do surveillance imaging to determine it?
Yes, I think we were also astonished by the results, I have to say. I think we have still a way to go, but it might be a promising diagnostic test, non-invasive, also, as you say, for family member. It might be interesting to look also for it in patients with atypical FMD, as you have described. But we need to have a larger cohort, and also with all the subtypes, the phenotypes of FMD. This cohort includes patients with predominantly renal FMD. Many of them have multivessel FMD as well, but I would like to see again in a predominantly cerebrovascular cohort, for example, etc. But let's say that the post-hoc analysis we did it in our group, which is moderate size, does not seem to indicate difference between these phenotypes. So yes, I think it can be a promising tool, but we are working on it.
Because as you know, Jason Kovacic and I and others published the proteomic data on FMD, and the accuracy of that was somewhere in the 70% range, not ready for prime time. And yours was a pilot study, so it'd be interesting to see what happens with that with larger numbers of
absolutely
patients. I think we're going to hold the rest of the questions. I see some questions there. We're going to hold them till later, just so we can stay on time. And
For sure.
so thank you, Alexandre.